Hello, ladies and gentlemen, and welcome back to our dermatology section. This will be an overview of skin cancer. We're going to talk about 3 of the major skin cancers. I'm going to go into each of these in their own individual videos. This talk is going to be primarily focused on the histopathology of skin cancers, just a brief introduction to all 3 of these. As far as diagnosis and treatment, I'm going to go into a little bit more in the in subsequent videos. This will be a really good video for you if you're taking step 1. It's pretty much all you're going to need to know for step 1 because I'm going to primarily talk about histopathology here. And on that note, if you haven't watched my videos on introduction to dermatology, basics of dermatology, I would suggest that you watch those because this is going to build upon that. In subsequent videos, I'll go into more of the treatment. That's going to be more useful for you if you're taking step 2 and 3. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button on the upper right hand corner if you hover up here. And it should link you up. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, formulating differential diagnosis, treatment plan, things that will come in handy for you for your clinical practice and as you begin to think towards step 3, clinical case scenarios. And it's really good to have sort of a formulaic way of going about approaching each patient because that will really help to impress your attendings as you're in the wards. So thank you very much in advance for your consideration. So we're going to talk about 3 different types of skin cancer, primary cancers that involve the skin, malignant melanoma, squamous cell carcinoma, and basal cell carcinoma. Another important cancer that does originate from the skin but is considerably less common and less tested is the eosinophilic granuloma, formerly known as histiocytosis X, which arises from Langerhans cells. This is a little bit less tested on, but it still does get tested on, so I will do a video on that. But you don't need to know that one in quite as great of detail as these 3, because these 3 are fairly common, and they are certainly fair game for the USMLE, that is for sure. So we'll start with malignant melanoma. This is a malignant neoplasm derived from melanocytes. Now, every tumor, every cancer that you go over, as you're going over them, the very first thing you should understand is where do these tumors derive from? What kind of cells? All tumors, all cancers derive from normal cells that have been mutated now to be cancerous. And so these derive from melanocytes. Remember that normally you see melanocytes where? You see them in the stratum basale. And so that's normally where they are. Now, when you get malignant melanoma, these cells will appear elsewhere in different layers of the skin. The benign equivalent of a malignant melanoma is a nevocellular nevus, also known as a mole. And everybody's got moles, so you should be able to find one on yourself and look at it and see how different that is from a malignant melanoma. Nevocellular nevuses, or nevi, moles, can transform into malignant melanoma, so if you have a large mole, that's something you always want to keep an eye on. The epidemiology. The American Cancer Society estimates that about 96,480 cases will be diagnosed in the U.S. in 2019. About 60% of these cases will be in men. The incidence is rising in part due to the aging population and to the fact that this is more common in older people, but also due to the fact that around the 1970s and 1980s, people started using cancer beds. Tanning beds. And the more that people have used those, and unfortunately young people continue to use them, you get sunburns, you get more UV exposure, and it's really problematic. As you can probably imagine, whites are at the most at the biggest risk of developing malignant melanoma, and really any skin cancer. It's going to be more prevalent in whites than in other ethnic groups. And if you compare whites to blacks, for instance, who have the most pigment, it's 20 to 1. So blacks do get skin cancer, malignant melanoma, but it's much more common in whites. Only 1% of skin cancers are malignant melanomas, but by far and away, malignant melanomas make up the vast majority of skin cancer deaths. The other 2 skin cancers, primary skin cancers, are not really deadly. At least they're not deadly when they're diagnosed in a timely manner. But in many cases, malignant melanoma is not discovered until it's a pretty dire situation. Malignant melanoma peaks around ages 40 to 70, median diagnosis around 60 years of age. But it is a significant cause of cancer in young people. And I believe I read, don't quote me on this, that is the most common cancer in people in their late 20s. So that's a big problem. There are occupational considerations you need to consider. So anybody that's out in the sun a lot, that isn't using sunscreen, like construction workers, farmers, they're at higher risk. Lifestyle habits, obviously people who sunbathe, people who go to tanning beds, they're definitely at higher risk. Risk factors include chronic sun exposure and sunburns, fair skin color, somebody like me who's Scandinavian, I burn very easily. I was just in Peru last month, hiked up a mountain, burnt my entire forehead. I wore sunscreen, but I didn't get it on the very top of my head, you know, closer to my hairline, and I had a pretty nasty burn, which looked really funky because it was just part of my forehead. But in any case, people who burn easier, tan easier, they're at higher risk. Dysplastic nevus syndrome, which is an autosomal dominant condition. Familial melanoma, which is the condition is basically a loss of function of the P16. And then, as mentioned, it can arise from pre-existing nevi. So if you have large moles, that's something that you want to keep an eye on. Gross appearance. So the way to remember malignant melanoma is A, B, C, D, E. A stands for asymmetric. B stands for irregular borders, and we're going to see pictures of these. It'll make sense. C stands for variegated color, meaning different colors in the same mole. D stands for a diameter of greater than 6 millimeters, which is roughly the size of a pencil eraser. And E stands for evolving or changing. If you see a mole that's been around for a long time, but now suddenly it looks different, that is a big red flag. And remember that because these are derived from melanocytes, many of which are still functioning, these will be pigmented moles, very pigmented. Okay, so this is the gross appearance of a malignant melanoma compared to a benign nevus. Notice with the benign nevus, it's fairly symmetrical. It's smaller. You can't really tell with this because it doesn't show you a little ruler on the bottom, but you can if you look at these on your own body, you'll probably see a lot of moles. They're fairly small. Again, they should be less than the size of a pencil eraser. Any bigger than that, you really have to keep an eye on it. Notice the color; it's pretty uniform. So this is a benign nevus. Now compare that to this malignant melanoma. Obviously, very ugly, different colors. You can see that's your C. The borders are fairly regular. However, notice that it's asymmetrical. The diameter this is slightly bigger. Again, it's hard to tell because we don't have anything to compare it to. And then you'd want to know, is this an evolving tumor? Does this look different? Does this possible mole or possible cancer, has it been changing? And it's very common to see two different colors with the malignant melanoma. You'll see kind of a more inflamed reddish color and then a very highly pigmented kind of bluish purple color. So here's another example. Notice that the borders are irregular. It's kind of zigzaggy. It's also very asymmetrical. It's very pigmented. Notice that you've got a little bit of I don't know if this is like keratinizing going on here, but you can also see that sort of whitish color with malignant melanomas. And then again, we don't know what size this is, but just keep in mind, bigger than a pencil eraser, red flag. Here again, you see very irregular borders, asymmetrical. You see different colors here, pigmented kind of along the outside, a little bit reddish and whitish on the inside. This is possibly a little bit smaller, or maybe the picture was taken a little further away. This one's a little bit harder to tell. It looks like it would be possibly a little bit smaller. But you have the variegated coloring. You've got asymmetricity. So this is also malignant melanoma. If you don't know, you're always going to get a biopsy. So you'll never diagnose these clinically. You're going to get a biopsy and you're going to look at it under a microscope, and that will tell you for sure if it's melanoma or not. So here's another one. There are 4 types of malignant melanoma. If you're the 99 percentile kind of person, you can memorize all of these. However, you should know what the most common one is and the one with the worst prognosis. So the first one is lentigo maligna melanoma. This has the best prognosis. It's typically on older individuals on sun-exposed areas. So lentigo maligna melanoma. The next one is superficial spreading melanoma. I boldface this because you should remember malignant melanoma, the most common type is superficial spreading melanoma. Now, in general, melanomas will grow horizontally and then they'll grow vertically. So they'll get bigger and then they will start to grow downwards deeper. And that's where it's a big problem because prognosis is directly correlated to how deep the invasion is. So it starts to grow. And of course, when you're looking on the body, you can only see horizontal growth. So this one does grow horizontally and then it grows vertically. This is the most common malignant melanoma. The next one is acrolentigenous melanoma. This is the more common melanoma in darker skinned individuals, tends to occur in the palm, soles, and subungual areas. Coincidentally, those are areas that tend to be depigmented in a dark skinned individual. I remember I've got cousins that are African American. Obviously, when I was 5, 6 years old, I grew up in a rural area, so I didn't really know any African Americans aside from them. I remember looking at my cousin's hands and seeing how the palms of their hands looked just like mine, and I thought that was so cool. So if you look at the palms and soles of anyone, they tend to be pretty close to the same color, even though the pigment on their skin, the rest of their skin is not. So those parts of the body are at similar risk for melanoma. So typically in darker skinned individuals, if you're going to see a malignant melanoma, you'll see it on those parts of the body, more likely. And then the nodular melanoma, as its name suggests, it's more of a 3-dimensional tumor. It's not as flat because this one grows more vertically. And the reason that this has the worst prognosis, as you can imagine, is that the depth of invasion is directly correlated to the prognosis. So because this one is so apt to grow vertically, it has a worse prognosis. The nodular melanoma, worst prognosis. So the microscopic appearance, this is an asymmetrical and poorly circumscribed tumor with consumption of the underlying structures. As you're going to see, the underlying structures are very much abnormal. They're very disturbed. You'll see nests of melanocytes. Now you should remember, if you watched my introduction videos, what melanocytes look like. They're slightly less. The surrounding cells of the stratum basale are very basophilic. These are very pale, with pigment around them. And they sit at the base of the epidermis. So you'll see those cells, but you'll see them in the epidermis, in the dermis, and they tend to make nests. They also tend to have prominent nucleoli, and you may see some mitotic figures if you look close enough. The tumor marker for malignant melanoma is S100, but you don't necessarily need to know that because it's not very well studied. But I would remember S100 for malignant melanoma. It may get tested. If it is, that's an easy point. Okay, so I got this from Yale Histology, and this is just a beautiful picture of a malignant melanoma. So notice here we have the epidermis up here, staining a little bit more basophilic, all the way up to the stratum corneum, and then you have your Reitz ridges coming down here and your papillary dermis coming down here. Sorry, I wasn't really pointing very well. So this is down here is your stratum basale, all epidermis going up to the stratum corneum. So this right here at the very bottom of the stratum basale, at that layer, would be the normal place to see melanocytes. Remember that at the dermal epidermis junction, you will see this sort of zigzag pattern. That's totally normal, but this will get disturbed in a melanoma. Remember, the name for these little invaginations of the dermis, the epidermal part, is called Reitz ridges. The dermal part is called papillary dermis. And then coming down here, you have more of a reticular pattern in your dermis. So these nests here are the tumor. These are nests of melanocytes, and this is obviously very abnormal. If you go back and look at what normal skin looks like under a microscope, it doesn't look anything like this. So you see these little nests of paler staining melanocytes in the epidermis. It will be in the epidermis first and then ultimately migrate down. And what you want to know, as you're going to see, is the deepest part. You see these nests of melanocytes, these abnormal melanocytes that shouldn't be there, because that's going to give you help give you your prognosis. As we're going to see, there's a way of classifying these. So again, here you see a very beautiful nest of well, I don't know if you call it beautiful because it's cancer, but a very nice picture of a melanocyte nest. Obviously, again, disturbing the surrounding structure. So more nests of melanocytes. Just remember that melanocytes stain paler than the surrounding epidermis. More nests. See, really dense here. And this one's a little bit harder, but you can see again here these paler staining cells where they shouldn't be. Okay, all the way up close to the stratum corneum. It should not be here. You can see a little bit of pigment as well. That's going to be prominent along these cells. And again here you see destruction of the normal tissue geography with some pigment around here. Plenty of melanocyte nests, not quite as big as the other ones. But again, you see it in the epidermis. You should always see your nests in the epidermis, because this grows first horizontally and then it grows vertically in most tumors. Here is a really good view of a pigmented portion of the melanoma. You see lots of pigment down here. It should differ from more of the normal areas. Normally, you would see very uniform distribution of pigment. Here, again, you see a melanocyte nest here and here. Okay, so the prognosis, as I've mentioned a few times, the survival is inversely correlated to the depth of invasion. There are a couple ways that you can determine a level of the melanoma. This is not the same as grade, but these levels are associated with a certain survival level. I like Clark's levels, but you can also look up another one called Breslow. And it's really just based on the depth of invasion. So level 1 just goes into the epidermis. Level 2 goes past the papillary dermis, so starting to get into dermis. Level 3 goes to the papillary reticular dermal interface, which is where you've got a change from the papillary dermis to the reticular dermis. Again, they're very distinct tissues, so you should be able to know the difference. Level 4 goes into the reticular dermis, and level 5 goes into the subcutaneous tissue. So if you see it at the level of fat, you've got a big problem. And so the 5-year survival differs very much between level 1 and level 5. Okay, moving on to the squamous cell carcinoma. This is a malignant neoplasm derived from keratinocytes in the epidermal layer. Remember, keratinocytes are what we think of when we think of skin cells. And so these cells will look a lot like the cells that you see in the epidermis, in particular in the middle layers of the epidermis. This is the number 2 most common skin cancer next to basal cell carcinoma. The exact numbers are difficult to estimate because these are so common that they're actually not reported to the cancer registry. So we don't really know exactly how many. We estimate around 1 million cases in the US per year. So very common. Incidence increasing along the same reasons as why the melanoma is increasing. More common in whites, fair skin, people who live closer to the equator. So if you're a white Scandinavian living in Florida, you're at a high risk for squamous cell carcinoma. Typical age of presentation is around 70 years. This is almost always going to be in elderly people, older, middle-aged elderly people. If it occurs in young people, especially children, then you should think of a congenital condition, namely xeroderma pigmentosum, XP. Risk factors include chronic sun exposure, chronic wounding, any kind of chronic inflammation, fair skin color, exposure to hydrocarbons, occupational, burns, radiation, immunosuppression, and XP. The gross appearance, so this tends to look like a scaly papule, and a lot of times it's going to ulcerate. Usually it occurs on sun-exposed areas, so think face, arm, and hands. So you can see here how this is really scaly looking. Okay, it almost looks like like seborrheic dermatitis, but in a very, very, very discrete nodular region. So again, you see it here. This one's scaling a little bit darker. It's not so much because it's pigmented, it's just because there's a lot of keratin. Again, you see it right here. These tend to be very nodular, whereas melanomas are flat, usually. Okay, so you see another one here. This is marked for excision. The microscopic appearance, this will really help you. So there's a very characteristic appearance for squamous cell carcinoma under microscope, and that's going to be nests of atypical keratinocytes which invade the dermis. Remember, keratinocytes are part of the epidermis. They should not be in the dermis. Also, you get this formation of keratin pearls, and that's really going to help you. If you see those, you'll know that you've got a squamous cell carcinoma. They appear in other cancers as well, but they are very characteristic of squamous cell carcinoma. If you see the skin lesion, you get a biopsy and you see keratin pearls, you know exactly what you're dealing with. And then also intracellular bridges or desmosomes between the tumor cells. Okay, so let's see. I think that's all I wanted to talk about here. I got some pictures. Okay, so here are your these will invade the dermis, because remember that your keratinocytes are totally normal in your epidermis. So when they invade the dermis, they're going to be darker appearing. Just in general, the epidermis stains darker than the dermis. So if you start seeing nests of darker staining cells in the dermis, you know you're probably dealing with either a squamous cell carcinoma or a basal cell carcinoma. This is a squamous cell carcinoma. You see these little pearls of keratin here, which when you look closer, they have this sort of onion peel appearance, this onion skin appearance to them, and that's keratin. So look at that. Very obvious here when you look at it, and this is in the dermis. Okay. Now here you can see that intercellular bridging here, and what are these? These are desmosomes. Okay, and desmosomes are normal that we see in the epidermis between keratinocytes. So it makes sense that they're going to appear in a squamous cell carcinoma, which is made up of cancerous keratinocytes. Okay. The prognosis for squamous cell carcinoma is excellent. Fewer than 1% die. And just like with the melanoma, the prognosis is linked with the depth of invasion. All right, and then finally, the basal cell carcinoma. This is a malignant neoplasm derived from basal cell keratinocytes in the stratum basale base of the hair follicle. So this derives actually from epidermis that surrounds the hair follicles. Remember that the hair follicle is an invagination of epidermis, so it has all the layers of epidermis. It's just deeper down into the hypodermis. So these are derived from basal cells. Remember, basal cells serve two big purposes. One is that they provide the stem cells to the epidermis, and then two, and not so much important for our purposes here, is that they help attach the epidermis to the basement membrane. The epidemiology of basal cell carcinoma is that it is the most common skin cancer, so you should know that. Approximately 900,000 cases diagnosed in the U.S. per year, but it's, again, probably a lot more than that, because that's just the number that actually get diagnosed, but there are probably a lot that don't get diagnosed. The incidence is increasing, more common in whites and fair-skinned people, and men outnumber women about 1.6 to 1, probably due to occupational sun exposure. Interestingly, just today, I took my grandma to the dermatologist to get a basal cell carcinoma on her nose removed, so this is very, very common. Usually it occurs in people over the age of 40, which my grandma certainly is. She's 93. When it occurs in children, think, again, xeroderma pigmentosum. Risk factors include chronic sun exposure. My grandma used to live in Florida for 35 years. She used to go down there every winter. So that's definitely her. Fair skin complexion. Grandma is, her parents are from Norway. So again, immunosuppression, and xeroderma pigmentosum. The gross appearance, this tends to look like a pearly papule or nodule with telangiectasias. Are you always going to see telangiectasias? No, but if you do see them, it's probably a basal cell carcinoma. It may also appear as an erythematous patch, so that looks a lot different from a pearly papular nodule. So this has a variety of appearances, but I imagine if you get this on the USMLE, they'll show you a pearly papule with telangiectasias because that's a really obvious appearance. If you get it on step 1, they may show you a picture, a microscopic specimen. It can be pigmented, so in that case, you need to watch out because if it's pigmented and it's a patch, it can look kind of like melanoma. Again, very, you're never going to really look at these and then be asked, unless it's a stereotypic classic picture. If it's anything in between, you're not going to be asked to look at, if it's, something that even a dermatologist wouldn't know looking at it, if it's a melanoma or a basal cell carcinoma, you're not going to be asked to determine what it is just based on a picture alone. If it's up in the air, you'll be given at the very least a histologic specimen. And these look very different histologically, but sometimes macroscopically they can look very similar, or at least, kind of in that question region. Most commonly occurs on sun-exposed hair-bearing areas, so particularly the face, the nose, the forehead, the scalp. So you can see here a very pearly, shiny papule with telangiectasias. Here again, you can see telangiectasias if you look a little bit closer. This is a little bit flatter, but you can see pools of blood vessels. More telangiectasias, very pearly-looking lesion. This is a flatter one, so you can see it's a little bit different. Maybe if you looked up really close, you may see some telangiectasias, but this is flatter. It should be kind of rough, typically not tender though. Again here, you see some telangiectasias up here, but this is pretty flat. So you can see kind of a variety of appearances for the basal cell carcinoma. Microscopically, you'll see nests of purple basaloid cells with a palisading growth pattern. Remember, where the name basal comes from is that it's basophilic. And so you've got darker looking cells. And if you look at your stratum basale, you see very dark staining cells. And so these cells will start to invade the dermis. So this is not a great appearance of a basal cell carcinoma. But you can see that it's much different from the dermis that it's currently invading in. This is a much better appearance. So this is a basal cell carcinoma in which, obviously in very thin skin, but where the basal cells have definitely invaded the dermis. And it has this palisading pattern, which I've got some other pictures that are a little bit more clear for that. So, okay, so notice that these, so you've got obviously your very large invasion of basal cells into the dermis, but notice how these nuclei are elongated, very elongated nuclei, and sometimes they can run parallel to each other. That is called a palisading appearance, and that's characteristic of a basal cell carcinoma. Again, you see here, not only are the nuclei of the nests very palisading, but you see some palisading as well of the tissue surrounding it, the elongation of the nuclei. So again, dark staining cells in the dermis, and you shouldn't see any keratin pearls whatsoever. That's the squamous cell carcinoma. Again, you see it here. Look at these cells here. Look how elongated they are, particularly on the edges. It's like you took the cell and stretched it out like putty. That's the palisading pattern. And then this is a nice picture I found online. Little cartoon here distinguishing the basal cell carcinoma from the squamous cell carcinoma. Both have very good survival, very good prognosis. A basal cell carcinoma, yeah, it can kill you, but it would take like 30 years. So, and typically these happen in older people. So, they're probably going to die of something else before they die of a basal cell carcinoma. But they can get really large, kind of disfiguring, ugly looking. So we almost always take them out. Plus, sometimes you can't tell them apart from melanoma. So you got to be careful. If you don't know, get a biopsy. And that's all I've got for you. If you have any questions, write me a note below. Otherwise, I will see you as we go on to talk about each of these tumors in detail.